Hello, and welcome to Strategic Position Foundations for Managing Developmental Dysplasia of the Hip. My name's Charter Rushing. I'm a physical therapist and a doctor of science. At the end of this presentation, the participant will be understand the key principles of developmental hip dysplasia, including risk factors, signs, and symptoms to enhance early. 2, learn effective positioning techniques and strategies that therapists can implement to support children in achieving optimal hip development and alignment. And 3, explore evidence-based interventions and therapeutic approaches to the developmental stages of children with hip dysplasia, fostering function and minimizing long-term complications. So first, let's talk about just key concepts, and we're going to go into a lot of detail on all of this in this upcoming presentation. So at the time of birth, it's important to understand that the hip is inherently unstable. The acetabulum is shallow and it's half cartilage. The femoral head is all cartilage. The ligaments are lax. And kind of one of these key concepts we're going to be kind of going over again and again in this presentation is the shape of the acetabulum is determined by its contact with the femoral head. And then after birth, the acetabulum grows past the femoral head, and this is in an attempt to gain more coverage and to make the hip joint stable again. So this presentation is going to be really focused on going into the literature, and let's look at the literature and the foundational publications that have been put out there by some really monumental clinicians. And this really establishes the baseline of where current treatment is. And then it also helps us to formulate what we should be doing in children with their hips in terms of positioning with therapy. So we're going to start off with Salter, and he has a famous article called The Etiology, Pathogenesis, and Possible Prevention of Congenital Dislocation of the Hip. And then we're going to move into each one of these articles after that in succession and really just uncovering a wealth of treasure and knowledge that's going to guide what we're going to do with our children today. So this was published in the Canadian Medical Association Journal back in 1968, and the title of it was called Etiology, Pathogenesis, and Possible Prevention of Congenital Dislocation of the Hip. And Robert Salter is a famous physician from Canada. It's happened in pediatric orthopedics and how we think about treating children. And this article is really one of those kind of foundational articles that everybody should know about. You should know how to find this on Google Scholar. It's free to download, and I really recommend this as an article. Everyone in the healthcare field dealing should read this and really go into all the details on it. And that's what we're going to. So one thing that we really want to focus on here is, since it's detection at birth requires a specific method of examination, and it's still not recognized sufficiently throughout the world. And this is something that if we don't get on to hip dysplasia early, then we have a much harder time treating it. And that's really what's going on in this part of the article. Is he's trying to emphasize the importance of recognizing hip dysplasia early, and the earlier that we recognize it and we start treating it, the better chance we have of having good results. If we wait too long on treating hip dysplasia, then we really start having problems, and treatment is less satisfactory. And if it's not treated early, then it will lead to degenerative arthritis in the adult hip. And as we'll see later on, also in children with developmental motor disorders such as cerebral palsy, the children that have less abilities to ambulate are going to be at a higher risk of having hip dysplasia and also painful hips by the time they enter young adulthood. So this is really an important concept. Hip development is something that starts early. It happens around the time of birth. It's a real sensitive time around the time of birth, and then we want to treat it early and maintain proper hip positioning throughout life to avoid any problems. So, one thing that's different about congenital hip dysplasia, and that's kind of what he's going into here, is things like club foot or spina bifida. The deformity is already maximal at birth. It's not going to get any worse as the child gets older, and if anything, as you treat it, things will get better. That's different than congenital hip dislocation. So, in congenital hip dislocation, the anatomical deformity is minimal at the time of birth. And and if it's left untreated, it gets worse over time after birth with postnatal growth. So this is really an oftentimes it's not like the hip is at its worst. Usually what happens is if we don't treat it right and if we don't position them well, the hip will get worse over time, as opposed to something like club. It's not going to get worse over time. It's already at its macroplasia. It could get worse. So that's something. So let's talk a little about the hip and how it develops. So the hip develops around the 10th week of gestation, and that's when face appears, and therefore it becomes possible for the movement to start to occur. And it's reasonable that the hip's not going to be dislocated at the beginning of its formation. So club feet, for example, they start club foot starts to deform very early, like a fourth, fifth week of gestation, and that's when you see the club foot deformity. You can see club feet ultrasounds um, pretty clearly just at around 3 months or so. But with hip dysplasia, we're not going to start off with the hip being dislocated. The hip dislocation is going to happen later on. And so that's kind of what it's something that must happen during the late prenatal or early postnatal development that produces the. So, a few things about the hip. I mean, the typical adult hip is one of the most stable synovial joints of the body. And I remember when I did gross anatomy, one of the things that we did with the cadaver is when we got to the hip joint, we tried to dislocate the hip, and it's really, really hard. And it's negative pressure, and you can put the hip in, and it's kind of hard to get it to pop out. So really, the hip is designed to be inherently stable, and there's going to be things that contribute to this stability. Some of it is just the shape of the hip. So the hip is going to have a socket, which is going to be the acetabulum, and it's going to have a femur, and it's a ball in a socket. And when you have a fully developed hip, it's going to be fully covered by the acetabulum, which is going to give it a lot of bony inherent stability. The other thing that's going to give it stability is going to be the muscles. So you got some big flexors, you have your gluteal muscles, and these are big, heavy muscles that are going to help to kind of keep it out of like the rotator cuff of the leg, just like the way we think of our rotator cuff gives our shoulder stability, the muscles around the shoulder, the muscles around the hip also provide it stability. And then finally, the capsule and the ligamentum teres, acetabulum to the head, those two features also provide the hip with a lot of stability and pre-rotated. So if you were to take a rag and to twist it, the rag would kind of tighten up, and the hip is already kind of rotated a little bit into internal rotation, and that also helps with some of that stability. Is that at the time of birth, the shape of the hip joint surfaces are really pretty much normal. Talking about that here. But then what happens is if these problems that we'll talk about continue, then the hip will continually deform over time. And so that goes back to that concept that in order to a typical hip, we're going to have good contact between the femoral head and the acetabulum. And the minute we don't have good contact anymore, then we'll start to see progressive changes in the shapes of both the femoral head and the acetabulum. And then even in studies with paralytic dislocations, for like so that muscle imbalance alone can result in hip dislocation, but again, it only happens early and it's something that happens over time. And then if the congenital dislocation of the hip and surrounding muscles are normal at the time, really start to look at the capsule. And that's really one of the things that they start to find being a problem is that the hip joint capsule is really something that can be lax. And some of that could be related to hormones that are being passed on from the mother because the mother has hormones passing through her body in order to make it easier. So the ligaments become lax during that time period, and some of those hormones pass on this, and that could be causing some of the problems as well. All right, let's go into just some specific facts about the incidence of congenital hip dislocation that have been around since Salter's time, and these haven't really changed a lot. So, number one, when we think of hip dysplasia, we think of 1 to 1.5 per thousand live births. And that's going to be a pretty typical kind of reporting that you see of that. And so, if you think about the population in which you live and how many babies are born each year, that gives you an idea in terms of its incidence. So again, this is an incidence that's in terms of live births, not in terms so much of a total population of people, and that's quite common when you talk of it. And clubfoot, for example, is very similar in its incidence, about 1 in 1,000. So the thing that we also see is that there may be some racial variation that could kind of make us think that there could be a genetic issue. And so that's where we go in here. So in approximately 20% of children with hip dysplasia, they have a family history of it. But it's not that hereditary reasons describe the majority of patients that have hip dysplasia. So only percent of patients will have that family history, and that leaves about 80% that it's the first doesn't appear to have a genetic cause. And then this is dysplasia. This is when we talk about incidence and etiology and prevalence of condition. It's really important to note female versus male. And you're going to see here that 80 to 90% of children with dysplasia, or we'll talk about in a little bit how even hip problems that happen later in adult. One of the first things we want to know about our patients is it male versus female? Because our females are going to be the ones with the highest risk of actually having some type of developmental hip dysplasia in their past history. It probably, it most of this is going to happen shortly after birth, and likely within the first 2 weeks. So that's going to be one of the other key things. And earlier, but we kind of think children most of the time are being born with hips that are relatively, there then could have some risk for it developing. So we children being born, and then right after that time of birth, that really high incidence of hip dysplasia. Now, when we have children with developmental disorders and developmental delays, we want to reach them for their hips because part of what's going to help that hip shape is going to be the positioning of the hip, the movements of the muscles around, actually even standing and walking. That's going to also help kind of develop the hip. So when we have children that aren't meeting those types of milestones, we always want to be a little careful that their hip may not have fully developed yet and be fully stable. And then this gets down to this geographical and racial incidence. So this is something that's really unique to congenital hip dislocation. And Yes, we do see these drastic geographical and racial differences in terms of hip dysplasia. But it's not so much for the genes as much as it is for the caregiving tactics. And so, what's going on in these pictures is you're seeing all these infants being held in positions of hip flexion and hip abduction. And we're going to find, and if you will look at a Pavlik harness a little earlier, a little later on in this talk, is that that positioning is super important. And when we're not in that position, that's when we really start putting the hips at risk. So this oftentimes when we see and racial differences, we're like, oh, this is all genetics. But really, as they started to study the hip dysplasia populations, they really started to find that a lot of this is an example of a child in a cradle board. And children, these types of caregiving practices with children lead to a much higher risk of hip dysplasia. And we're going to really pull that out in an article in a little bit so you can see the impact of hip positioning. And really, what you should be looking at here is when you put infants or you swaddle them with some type of diaper that's going to force their hips into extension and their knees into extension, that's going to be a big warning sign. That's the positioning you don't want. And I'm going to I'm going to expand on that a little bit. So this is an infant. So first thing, in infants, you never force hips into extension and you never force knees into extension. And I'm going to really drive this home throughout this talk. Um, but I'll take that a bit further and I'll say any child at risk for hip dysplasia, you never want to force their hips into extension and you never want to force their knees into extension. And this is going to start becoming really more visual here in a few minutes. So we what he's talking about here. So the hip is protected by postnatal position of flexion and abduction, and it's made worse by a postnatal position of extension and abduction. Hips. Flexion is healthy, abduction is healthy, postnatal positioning of extension and adduction, so forcing hips into extension and adduction is bad, going to make things worse. And this is just another example of a child being tightly wrapped in a blanket. And there was a higher incidence of hip dysplasia. And some of that is thought to be related to swaddled more and tighter blankets and the hips not being free and being forced into extension. And then the next thing to is the relationship of children being born in a breech position and that causing hip dysplasia. And so what you see is that 23% of all children with congenital hip dislocation have been delivered in a breech position. And we're going to go into some real detail on why the positioning of a breech position. So a breech position is when you're not head down, you're head up. And when you're in that position, your bottom is kind of settling down into the base of the uterus and your knees are usually fully extended. Your hips are flexed, your knees are extended, and you kind of look like you're in the jackknife position, like if you were doing a dive off the diving board. And we're going to find that what's really happening there is those knees getting forced into extension can also cause the hip to dislocate. Now, what do you see when you see a hip that's dislocated? So really help you to see what you're looking for. So the Ortolani sign of instability with slight adduction and pressure along the long axis, you can actually dislocate and subluxate the hip. And so that's kind of what they're doing here. And then what you can also do is you can provide some traction to the femur. And as you're doing that and you push in with your finger on the greater trochanter, sometimes you feel a click or a clunk and you can actually get the hip to relocate back in. Now, there's a few other things that you can look at here that kind of tell you you're having some problems with the hip. So right here, the hip is being dislocated, and you can see how much deeper this crease gets. And we see kind of an asymmetry in the creases. So oftentimes you'll hear this called asymmetric thigh folds. So that's one thing that you're looking for. And the other thing that you'll see here is less abduction when you're not able to abduct the hip as much. That's going to be oftentimes one of your primary clinical signs to know that you've got a hip problem. Hips, like this hip is healthy, should abduct, should flex fully and abduct fully. So it almost kind of 70, 80 degrees or so. And when you have that limitation into abduction, that's something that worries you a little bit about that hip. And you can see as the hip gets reduced, you see that long crease there actually reduces as well. And so what's happening is as the hip goes in, it's restoring the tension on the skin and the muscles, which is going to show you those changes in the skin as well. Here they were talking about the seasonal incidents. And then this goes into kind of how things get worse over time. So, right here, the hip is dislocated on this infant. You can kind of see the top of the hip right up here, and it's not in the socket. And but if you look at this hip compared to this hip on the X-ray, they don't look totally different. Other than this hip is just a little more vertical, maybe than this one, as far as the acetabulum is concerned. Now you can see right here, as the child gets older, you can see the hips dislocated. And now we really start to see big differences in the way the acetabulum looks. This one is much bigger. You can see that it's more horizontal and not vertical. And over here, you can see right here, it's kind of like it's missing the end of the hip right here, and it looks more vertical. And so the acetabulum will start to change without the contact of the femoral head in it. And then this will be what a hip would look like that was dislocated at 10 years of age. And you can see this is what an acetabulum should look like. On an X-ray, it should look like a nice C. And over here, it not really clear edges. See how clear these edges are here. And over here, we really don't have these clear edges. The hip is actually forming almost like a false joint up here. And the acetabulum basically by this point never developed. So that's what's going on in this hip dysplasia. And what they found is also that they found on the first day of life, 1 in 60 infants have instability of one or both hips. But of these hips, so that seems, God, that's a lot, more than 1 in 1,000. This is 1 in 60. But what they found is that the hip becomes stable. 70% of these hips became stable in 1 week, and then 88% became stable by the end of the second month. So it really only led to about 12% of that original group having hip instability, and that's where they get that 1.5 per 1,000 live births. And again, this is just showing that right at birth, that's the sensitive time when the hips are unstable, and then they quickly try to restabilize. And it kind of goes back to that the primary problem is congenital laxity of the hip joint capsule with instability of the joint. And it suggests that there's a capsular laxity to improve spontaneously, that the laxity improves spontaneously as long as the hip does not remain dislocated. So the theme there again is if you can get the hip in and you can maintain the hip in, then the acetabulum will develop and your hip dysplasia will go away. And then the other thing that they tended to find in this article, but we'll find some kind of different kind of case studies where that may refute some of this. But after the first year of life, the dysplasia is irreversible. And the acetabulum can be completely restored. And we'll see what I was trying to allude to is what we'll see in an article, even after the first year of life, there are still opportunities to remodel the hip. Was dislocated, And you can see once it was relocated and treated that the hip joint maintained its development. So let's get into kind of some things that cause a lot of problems at the hip. So they did some experiments, and what they did is they took some newborn pigs and they maintained the hip into extension for 6 weeks. And that's what's going on here in this picture. So they put this little pig in a spica cast, and the hip, so you can see this left hip here was kept in flexion and the right hip was forced into extension. And what is happening here is that this is what the hip joint should look like for a typically developing hip. So it should be kind of deep, and that's what the dark part is. It's a deep, well covered kind of hip. And what you can see happen on this pig is the hip that was maintained flexion looks like a typically developing hip, but the hip that was maintained into extension subluxated and dislocated, so you lost that contact of the femur with the acetabulum, and you ended up with this very dysplastic and poorly developed hip. And so I'll get a lot closer on that. So you can see this real clearly. See how deep this one is, and you can see how shallow this one is. It's not real deep, it's real flat. And so your acetabulum is not going to develop even when you have a normal one to start with. If you have a normal one to start with and then you dislocate the hip and you leave it out, then the acetabulum will degenerate and you will not have a hip anymore. Hmm. There we go. And so the results of these experiments suggest that maintained extension of the newborn hip joint has a deleterious effect on the subsequent development and has a beneficial effect. And so that's going to be one of the take-home messages is hip flexion is healthy. Or from this talk, what I want you to understand is hip flexion is healthy, and that's something that you always want to do with any child who's at risk for hip dysplasia. So going on here is when children are born, the hip joint is facing more forward and more lateral. Kind of what that's saying is if you're facing more forward and you extend the hip, you're going to have a tendency to slide up off the hip, and that's why if you flex onto a forward facing acetabulum, you're going to maintain that contact better. And so that's an important part too to understand just anatomically how the acetabulum is going to start off facing like this, and then eventually it's going to become more horizontal and be in a position for weight bearing. But when we're first born, it's facing more like that, and that's where having the hip flexion really helps to try to um, align better. And then the fact that it faces more lateral, so we have to flex to get in contact with the forward, and the fact that it's lateral, we have to abduct a little bit to get it in contact together. And then what he's basically saying here is what I was saying earlier. As soon as you lose that corrective force of the femur in contact with the acetabulum, then you will start to have problems with the acetabulum, and that hip is going to continue to face forward and lateral. And then what's going on in this slide here is they're actually showing, hey, in this hip, we dislocated it, and you can see how it's looking much more developed than this hip is. And then what they did, then they flexed, they took the pig out of the spica cast, and that's all they did. They didn't treat it anyway, they just took it out of the spica cast. And once they did and they allowed that hip to flex again, then the acetabulum actually restored itself and regrew. So that's another kind of big theme here is as long as you can get the hip into flexion and let it freely flex and do a little abduction, then there's a good chance that the hip may try to reconstitute itself and regrow. And then this slide is just showing how surgically, how you can also, so right here, what they did is here's the hip that is dysplastic, and they'll take some bone graft and they'll make a little cut in here and shove some bone graft in here. You can kind of see where it was, making the hip a little more horizontal. That can also help the hip to develop. And then what's happening over here in this picture is they also did studies on if you maintain hips into external rotation or maintain hips into internal rotation. And just to show you the effect of how that can affect the amount of retroversion or anteversion that can happen in the femur as well. To only be about 10 degrees by the time you're an adult. But what you'll see is if a hip, you won't have any correction of that femoral anteversion. So what we see is that femoral, rather than being the cause of dislocation, usually it's the result of dislocation. And kind of one of the take-home messages, being W sitting, oftentimes they're sitting in that position because they have femoral anteversion in and of itself usually is not the dislocating factor. So the most, again, there are just reinforcing that the problem then in hip dysplasia is that lax hip joint and the fact that we have to keep the hip stabilized, and too much force on the hip joint, the hip's likely to subluxate or dislocate. And here's just an arthrogram showing that. So this is, for example, like the ligamentum teres, and that should be a short little ligament, and it gets really long and stretched out. And for the hip to be dislocated for this period of time, it ends up really stretching out the capsule. And then here they're talking about that the phenomenon of the ligamentum teres being lax is related to maternal hormones that are going into the fetus. And then here they're starting to talk about how when children are born with a hip flexor contracture. So the iliopsoas muscle is tight. And here they're showing a picture of a cadaver, and they're showing the tightness of the iliopsoas. So this is a 1-day-old infant that unfortunately died of some heart defects. But you can see how tight the hip flexors are in a young child. And what's so important about this is, and this is what they're trying to drive home here, is when you have tight hip flexor muscles, those muscles are big and thick. That's like a tenderloin, okay? Think of it when you have a tenderloin at a restaurant, that is the hip flexor of a cow, and it's a big, thick, strong muscle. And so when children are born, those iliopsoas are really, they're tight, but they're protective in what they're doing. And having that hip flexor contracture and keeping the hip in a flexed position is actually good, and it keeps the hip where it needs to be so that way the acetabulum can develop. And instead, what happens is if you try to extend the hip, and that's what they're doing in these pictures, when they're showing in this cadaver that when you force the hip into extension, it starts to make the capsule kind of bulge. You can actually see the femoral head kind of pushing on it. And then what they did is they incised the capsule, and as soon as they did that, the hip pops out and it dislocates. So it just shows that that force of hip extension, you still have the iliopsoas intact and it's tight. If you try to force that hip into extension, the hip's going to give, and so anytime you force that hip extension, you're at risk for actually dislocating the hip. And so they use this anatomical model, and they showed that the hip actually dislocates when you put them into that cradle board extension position. And again, this is going to come back to haunt us when we talk about some of our children with hip dysplasia from developmental. The other thing that they're trying to teach in this model is there used to be the practice of pulling, maybe holding the child upside down and spanking them on the bottom, when they were first born, I think to clear fluids out of the lungs. But they're showing when you do that, when you hold them with traction and extension, that causes the hip to dislocate. And so that's what they're saying is that this, and then some kind of sudden passive hip extension actually cause it to the initial dislocation. And then also wrapping a newborn tightly with the hips and resident in the presence of a lax hip capsule can produce a permanent hip dislocation. So they're saying both of these practices are harmful and should be abandoned. So here they're showing just kind of the typical how they kind of hold the infant and spank them on the bottom. And then over here, they're showing again that same picture of the child being swaddled in a blanket, doing so, forcing the hip into extension. And so with swaddling, one thing, since we're looking at the picture here, there's no problem with swaddling infants. And really what you're trying to do when you're swaddling infants is trying to get the hands across the chest usually and give them kind of a good tight hug. And that makes them feel safe and secure and helps to calm their emotional state. But what we want to do is we want to make sure that we're not wrapping the hips into extension. So we can either leave the hips out of the swaddle or we can make sure that the swaddle is very loose on the hips and allow the hips to flex. And then here they come back and they reemphasize again, if the hips in all infants were protected by maintaining them in mild flexion and mildly dislocated hip did in fact dislocate shortly after birth, it would not remain dislocated and would not be a persistent dislocation. So again, this take-home message that hip flexion is healthy and forced hip extension is going to cause problems. Okay, so that is going to be our longest article that we go through, but it really sets the stage. That kind of came along after that, and they started to look at knee flexion and knee extension. And hamstring muscle crosses the hip joint, so that's another big group of muscles. You think about the size of the hamstring, and they cross the hip joint. And when we put force on the hamstrings, and when you're born, you have a bit of a hamstring contracture, just like the way you have a hip flexion contracture. And then they started looking at, well, what happens if you force the knee into extension? What effect does that have on the hip? And that's related to the breech position. And that's where these studies started coming from, because in the breech position, the hip's in flexion, it's in max flexion, so that's a good position. Then why would a breech position cause the hip to subluxate or dislocate? Why would we see more hip dislocations in breech position? And what we're going to find is the answer is because the knees are in full extension. So even when the hip is fully flexed and then you extend the knees into full extension, you're stretching those hamstrings and they can cause the hips to do mobilization of the knee in young rabbits that cause them to return to study the dislocation of the hip. Regularly cause dislocation or subluxation of the hips in rabbits less than 3 weeks old at the time when the immobilization was started. So what they did is they had these rabbits and they just had these plastic tubes that they could fit over the rabbit's knees, and the knee was just held in extension and the hip was allowed to freely move. So they could run around and walk and just were forced into extension. And they had a few other control groups. And then just test their idea that it's the hamstring muscle that could cause dislocation on a group of the rabbits that they put them into the little tube and force their knee into extension. They cut the hamstring at all from the hamstrings. And so what they were trying to see is it just the position of knee extension that causes the problem, or is it actually the hamstring that's causing the problem? So they cut the hamstring tendons of a few of these rabbits. And so this is what it looked like. So here's your baby rabbit with the plastic tube just holding the knee into extension. You can see that the hip is allowed to fully flex, and this is the typical position of the lower limb in the rabbit where the knee is in a lot of flexion typically. And so this is what you get. So when you force the knee into extension, you can see right here it causes a subluxation of the hip. So This hip is in. This is a hip without any kind of forced positioning and allowed to flex at the hip and flex at the knee. And you can see how it's covered by the hip. And then when you force the knee into extension, the hip starts to subluxate. And then, so that was after 1 week. So only 1 week of having the knee extended. Then by 2 weeks, the hip had completely dislocated. And then after 2 months, what you see is that there's a permanent dislocation and the acetabulum has completely been unable to develop. So take home message is if you forcefully extend the knee, you could potentially subluxate the hip. And we're going to come back to this a little later when we're looking at children with cerebral palsy who are non-ambulators. They're most of the time sitting than they are standing and walking. And what we're going to see is they also have very delayed development of their hips. They are always at high risk for hip dysplasia. And that if we extend their hips, if we extend their knees or we extend their hips, they're also at risk for these positional issues. They had some rabbits that they kept the knee extended with a intramedullary rod or nail, and you can see it caused the same problem. But this is really the interesting picture right here. So what they're showing here is that in this picture, so this rabbit had both knees held into full extension. And then after that, subluxation was seen only in the left hip. Now, what's going on here is both knees were held into extension, but the right hind limb, the hamstrings of the right one, the hamstring was cut. So this is the left one, the hamstrings remained intact and the knee was maintained in extension with the tube. And on the right one, the knee was maintained in extension with the tube, but the hamstring was completely cut. And this is what you see. And so on this one, 5 days later, or 12 days after the procedure, what you see is that the left one, where the hamstring wasn't cut, dislocates completely, and the right one maintains intact. And then if you go on to 27 days later, the right one maintained intact with the hamstring cut, and the left one is completely dislocated. So take home message here is tight hamstrings. They're also good. They protect the hip joint. They keep everything flexed. But if you force a tight hamstring into extension, the hamstring wins because the hip capsule is unstable and that causes the hip to subluxate or dislocate, which then causes the hip not to develop. And then this is an interesting picture too. So what's going on here is this rabbit was maintained in a plastic tube on the right side, the hip subluxated, and you start to see the dysplastic changes. They then took the tube off and they just allowed the rabbit to be free. They didn't force it back into flexion or anything like that. And then within 20 days after that, the hip completely reshaped itself. So also just how quickly the hip can remodel and change, and it can be restored. And that's the good message too, is like, hey, if you can restore the relationships of the femur and the acetabulum and get them in contact with each other, then especially as long as the child's in a growing phase, there's a chance that the hip can regrow and restabilize itself. Okay, so let's get to the summary. Here's the summary statement. The development of permanent dislocation or dysplasia of the hip in these experiments was dependent on the duration of immobilization, and if the hamstring muscles were cut either distally or proximally before immobilization in the knee, dysplasia of the hip developed. The prolonged tension of the hamstring muscles provoked by keeping the knee joint in is assumed to have been the main factor causing the dislocation and dysplasia of the hip joint in these experiments. That's reverse. So keeping the knee joint in extension is the can be a causative of dislocation of dysplasia in the hip joint. Okay, now let's go on to one final story, and this will kind of show how even on a population standpoint, how just changing positioning practices can have a big impact on hip dysplasia. And we want to keep these lessons at heart. This is all focused on infants and newborns. But when we have our other children who have hip dysplasia, these lessons can be learned, and we can also be advocating for better positioning strategies for our children as well. So this was done in Japan by Yamaru and Ishida. And so what was going on in Japan is Japan genital dislocation of the hip, and and their incidence was as high as like 5 to 6%, whereas typically developing populations who don't have are more about like 1%. So they started interacting and getting some education that was what we looked at earlier on from Canada, and they started to do some education. We're going to get down to that. So what they found is that the children in Japan were being placed in positions where the hips and knees were in prolonged extension. And from the beginning of postnatal life, they shouldn't be placed. They should be placed in positions that allows the hips to have free and spontaneous motion, and especially flexion of the hips and knees. They should also be given freedom of motion of the lower extremities and allowing gradual relief of the flexor dominant of the hips and knees. So, and what that's saying there is we don't force hip extension, we don't force knee extension. We allow it to happen gradually, and we really always want to be careful when we're going aggressively after these fractures. So, of congenital dislocation of the hip in Japan was very high, and this was they presumed related to diaper, and this was used wildly in Japan before 1965, and it resembles the cradle board that we saw from Native American populations. And so this is what the swathing diaper looks like, and it's forcing the hips and knees into extension and not allowing the hips to naturally flex and go into abduction and the knees to flex. So a started working on trying to improve the childcare methods in Japan. Caught on to a national scale in Japan, and eventually the Central Japan Association of Orthopedic Surgery and Traumatology held a big symposium on the prevention of congenital hip dislocation, and the Japanese Orthopedic Association presented an exhibition at an annual meeting in 1980. And they really focused not just on orthopedic surgeons, but pediatricians, obstetricians, midwives, health nurses, as many people as they could to try to go through this big education event to try to change the caregiving practices around birth related to the swathing diapers. And this is what you get. So you around 1973 or so, you have, these are L is a dislocation, and S is a subluxation, and the D is acetabular dislocation. How the incidence of these conditions reduce down to your below 1%, which is what you should see in a typical population. And this just reinforces how even a big education campaign and positioning can have a huge difference in a child's life and their hips being healthy. And again, hip positioning is powerful. All right, so let's go on to just a general article written by Storer and Skaggs. It was a big thing of lightning. It's raining right now. And what you can see here is this is just a good article on just an overview of where we are with, and this was presented back in 2006. But Things haven't changed a ton in terms of just how we think about. So it shows here the Ortolani and the Barlow maneuvers here. So the Ortolani is the typical thing that we're looking at where we want the hip to go in and you're providing a little traction and a little reduction on the greater trochanter, and you're hoping to feel that hip reduce. Just skin signs you look for. So you can see the asymmetry in the thigh folds here. So you only have one thigh fold here, but you got two there. So that's telling you that there's not tension on the muscles and skins and on the skin, and there's potentially a hip dislocation. When you flex the hips up, if this femur is dislocating out back behind the pelvis here posteriorly, you're going to see that the knee is going to look shorter on one side than the other. So that's the Galeazzi sign, hip abduction. And again, here, while you're looking for limited hip abduction, you can look for how there's a difference in the tension on the skin on each of these sides. But just a limit in hip abduction can tell you a lot about whether or not the hip is healthy and whether it's subluxated or dislocated. Um, and when they look at x-rays, just not that anybody here needs to be an expert in x-rays, but oftentimes they'll draw these helper lines. This is the triradiate cartilage, and they'll put a line through there to kind of give an idea of the hip sitting in relationship to those lines. And then they'll also draw a line at the end of the acetabulum, and then that helps you kind of know, like, hey, this femoral head is out here in this quadrant here. That's probably not in the right position, whereas this one's down in this quadrant and it's in the right position. Other things that you'll see on this x-rays, you can see how this hip is more horizontal and this hip is more vertical when you look at the acetabulum right there. So those are just some general things that you can see on an x-ray. Other things that they will use is they'll use this little area right here, and they'll draw a line, and they'll try to see if the line from here and the line from here intersect. And that also helps you to understand whether or not you have a hip dislocation. Really, what I wanted you to see in this article is the Pavlik harness. So treatment for hip dysplasia. And so when a child has some type of hip dislocation or subluxation, we want to put them in a Pavlik harness. They are going to be in that harness 23 hours a day. And what the harness is doing, what I want you to see, is how much the hip is flexing. So this hip right here is probably the dislocated hip. And it looks like actually both hips are dislocated, but I'd say this left hip is probably in a little worse shape. And things that I'm looking for here is it's not abducting as much as this side is. They're having to flex it a little bit more. So oftentimes they're trying to flex the hip up to about 120 degrees. And that's one of the important things as a therapist to recognize is hip flexion in these harnesses is really the treatment. That's the first thing they're trying to do. And when you flex a hip up into that position for that period of time, you could get a pinching of the femoral nerve. And so the femoral nerve is going to directly innervate the quadricep muscles. So if we ever are interacting with an infant in a Pavlik harness, we always want to make sure that they're kicking and they're firing that quad a little bit. And if they aren't, then that's definitely something we want to try to get them out of a little flexion. So if for some reason we're really worried about the quad, we want that caregiver to get them back in immediately to the provider who's placed the Pavlik harness, and they're probably going to need to reduce how much flexion the hip's in, so that way the pinching of the nerve's not so bad, and it'll start to come back and we get that quad function back. The hip, when you flex the hip up and the hip reduces, the hip will naturally go into some hip abduction like you're seeing on this side. And there are some straps, you can kind of move the straps around so they pull the hip more into abduction. But it's important to know that hip abduction is not the first thing we're trying to do. We're trying to flex the hip first, and that helps to reduce the hip. And then once the hip goes in, we should allow the hips to gradually go into abduction, and we don't want to force that. And This is why, because avascular necrosis of the femoral heads can be reported in the pelvic harness, and it may be related to hyperabduction. And so, in addition, hyperflexion has the potential for, if you're trying to get this hip in and you're trying to get in the right position, hip flexion is always where you start. And then you let the hip abduction come. You don't want to force the hip abduction. And then the pelvic harness, just for you guys to see how powerful and a success rate for acetabular dysplasia and subluxation. When you have a frank dislocation, that's down to 80%. And so, the goal of operative treatment too is to normalize the hip joint or delay or prevent premature onset of osteoarthritis. And we're going to see an article about that in just a little bit. But if we don't treat hips, then the hip will become painful by the time you're an adult. So they'll get premature degenerative changes and start to have problems as early as their 30s. And our children with cerebral palsy about hip health and how that's going to impact. All right, so let's talk about how far can you kind of push some of these ideas and concepts. What if you're dealing with an older child? So in this study, Papa Demetrio, they actually looked at using a modified method of the Hoffman-Daimler method. And so this is a Pavlik harness kind of based method, but it's something that they're doing in older children of late or a misdiagnosis. And what they found, complication rate. The general consensus, though, is harness after the age of 6 months. And so a lot of that is because some history that show the Pavlik harness decreases after the age of 6 months. But a lot of that is really related to the size and the strength of the child and their ability to keep the child in that flex position that they need, because that flex position needs to be maintained for several weeks. And that's kind of the hard part. The other thought is it was thought that older children have less cartilage remodeling ability to them, and maybe it wouldn't be worth. There's going to be a move to doing more surgical. But there has been some Daimler method that's intended, like the Pavlik harness, to be for older children. And we're going to learn some important things about this. They took children who had not been treated on and who had not been managed with an open reduction and a spica cast. And they had 9 boys and 6 girls. So I highlighted that because, again, it's that 80%, 90% incidence of girls versus boys, risk of having hip dysplasia in the average. And so this is a really showing in this picture is how when you look at the forces of the muscles, and so this is looking at muscle. So as when you put the forces of those muscles together and you combine them, and these are some of your glute muscles, their general forces are going to be to pull the hip up and out in this direction. And then the joints trying to resist that motion of the joint force going this way. Now, when you flex the hip, what we see is that the muscle force pointing this way and the overall force of the muscle is to actually pull the hip down and in this way. So that's part of what's going on. And one of the things I really like about this article is just this display of how just the positioning of the muscles, and when the muscles pull and fire and when they have the direction that they pull the joints. And so when the hip is adducted and the knees fully extended, the muscles around the hip, primarily the adductors, the iliopsoas, and the hamstrings, act to dislocate the hip. When you so the treatment of developmental dysplasia with use of the Hoffman-Daimler method involves putting the dislocated hip in flexion. And so Hoffman-Daimler brace and or harness, and you can see it's just a Pavlik harness that's being designed for an older child. And again, it's holding the hip into flexion. So the right hip here is being able to flex all the way up because it's reduced. The left hip has not quite fully reduced, so they can't get it all the way up into full flexion. And then the anatomical changes caused by the dislocation gradually reverse, allowing the femoral head to gradually move into the acetabulum by the redirected action of the adductor and flexor muscles of the hip. And we just saw that. Now, what they do next in this method, so first they flex the hip up. So that's important. And I feel like what's important about this article is it's describing the phases of reduction. So the first phase is flexion, and then the second phase is then adding a little abduction. And so you can see here, they are then starting to add an abduction bar here that can be adjusted. And they're trying to be really cool about this and trying to be slow about it too. They're going to keep the hip flexed, not force the abduction, because if you force abduction, it causes an avascular necrosis. And then once radiographically they determine that the hip's starting to get more stable, then they can let the child out of flexion. The child can walk, but they can maintain an abduction brace while they're walking to maintain that healthy hip position. And so these are the phases. So phase A is a flexion harness, and the key is to flex the hip. And they modified it a little bit. So number one, the hip flexion harness did not exceed 120 degrees, and abduction was never forced with the use of posterior straps. So that's an important concept here. Hip flexion and abduction is good, but we don't force it. The harness was used for as long as 150 days. So that's like almost 6 months. Gradually but spontaneously reduced. So it took a long time. And then phase B is when they start to add a little bit of abduction. So the harness, they add the abduction bar. And they show right here how the dislocation moves. So the head is way up here, it's dislocated. So phase 1 or A has these subphases. So first the head moves down, it slides down to here as you flex it. Then the next thing that happens is it's kind of got a bump over here and it goes medially. And then finally it goes back to here. So there's actually these sub phases that are running in phase A of what the hip is doing while you're maintaining it in flexion. And again, we don't want to had with bilateral dislocated hips and really no developed hip joint on either hip. Very shallow vertical hips. You can see the dislocation of the arthrogram and the hip capsule being very elongated like we saw in the Salter article. Here the hips are starting to reduce on one side. This one is irreducible. And then phase A, you see the hips starting to come down and get into place. And then during phase B, they can be doing standing, and you're starting to see hips actually starting to reconstitute. And then here's 27 years later, and we have completely formed hip joints with good coverage. So just to show that even with older children, the concepts of hip flexion and then gradual hip abduction are good. And then finally, this is just an article by Gons, and really what Gons is trying to do your arthritis as early as your 30s. But there's recent information that supports hypotheses, and the mechanism in these cases is femoral acetabular impingement, excessive contact stress. So even just a mild hip dysplasia can cause this osteoarthritis and this hip impingement that we probably hear so much about, people getting hip scopes and things like that. And again, if you're dealing with women, unrecognized and untreated developmental hip dysplasia predominated. So when they were dealing with this FAI, femoral acetabular impingement syndrome, Oftentimes they're seen in the women. And if you come down here, we see that Murray's work suggests that OA could develop secondarily to rather subtle, sometimes previously unrecognized deformities that occurred before skeletal maturity, and that the leading conditions contributing to these subtle deformities were developmental dysplasia of the hip. That's what we're talking about. And then there's also some femoral diseases that we can leave for another talk. In some of your hips, how when the femur flexes up and internally rotates, it pinches the cartilage, and that's what starts to cause the degeneration. Okay, now let's talk about, let's move on from children and let's talk about hip dysplasia. And the important thing to recognize here is it's not children just with cerebral palsy just all of a sudden develop hip dysplasia someday. Like they have hip dysplasia from the time they're born, and part of this is related to the positioning of their hips, not standing and walking. And we always want to think about our children with cerebral palsy being at higher. And those risk factors have been determined. So I want to scroll down here so you can see this chart. So our GMFCS levels, what it is it tells us what type of functional gross motor abilities a child. They get their gross motor development pretty similar. They're just a little delayed in getting their standing and their walking and their running and their jumping. And a GMFCS level 1 patient, they have the type of ability where they can go downstairs while holding a tray at school and be able to do that without falling or spilling the tray. Children with GMFCS are also independent walkers. They oftentimes are the children you'll see walking around. They'll have maybe a more pronounced kind of bilateral kind of presentation with their walking, stiff on both sides, quad canes or something to give them just, but they're not bearing their body weight on those devices. And they may also use a wheelchair for longer distances, especially in the community. Now, our 3, 4s, and 5s are children that are doing less walking. So our 3s, when they walk, they require the use of a walker. And usually it's a reverse walker that they can really bear all their body weight on their upper extremities. So they're not bearing a lot of weight on their lower extremities. And they're using wheelchairs much more often to get about in their daily mobility needs. Our GMFCS4s, when they ambulate, it's usually only in a gait trainer. They have to be physically put into the gait trainer and strapped in. And then they can only walk in that gait trainer in like a school area or somewhere that has level floors, because the gait trainer is not going to be able to go up and down curbs and handle uneven surfaces. And then our GMFCS5 patients, they're going to be completely dependent on a wheelchair for all of their mobility and are unable to do any ambulation even in a gait trainer. And you can see how ability level really affects their risk for hip dysplasia. And what are we going to see in these children? We're going to see hip flexor contractures and knee flexor contractures. And it's a very similar presentation to what we see with the newborn. And when we really went into that with Salter and those iliopsoas contractures, and we talked about the rabbits with the hamstring contractures, and those are things we oftentimes want to treat. I will show you that there are surveillance models now, and in just a little bit, I'll flip over to the internet and I'll show you where you can find the surveillance model. This is through the American Academy of Cerebral Palsy and Developmental Medicine. But kind of what you can look at here is here's the physical exam and here's the x-ray exam. And you can see as you get into the more involved children with less abilities, you're going to have to do a lot of exams on them and really be watching their hips from the time they're 2 to make sure that they have healthy hips. So this is something we like to do with children with cerebral palsy. The harder time they have getting around and ambulating, so our GMFCS 3, 4, and 5, they also tend to have higher spasticity, more hip flexor contractures and more knee flexor contractures. And as therapists, a lot of times we want to stretch these. But we're dealing with children that have hip dysplasia, and as we've learned, uh, prolonged positioning or forcing a hip into extension or forcing a knee into extension can cause the hip to subluxate. So, this group out of China decided to look at that in children with cerebral palsy. And so they state here that hamstring stretching is an integral component in children with cerebral palsy. And as the hamstrings span across the hip and knee joints, passive to the hip that is often called that is often dysplastic in cerebral palsy. So they're basically just saying that, hey, these kids have dysplasia, and when you stretch the hamstring, you're force onto the hip that may cause the hip to be unstable. More detail of that over here. So as hamstrings extend across both the hip and knee joints, contracture of the muscle would apply movement on the two joints simultaneously. Hypothesize that the force of pulling the pelvis against the femoral head may displace the femoral head when hip subluxation or dysplasia exists. So let's see what they found about this. So this was their testing apparatus. So they had children with cerebral palsy laying on in a CT scanner, and they had them kind of prepped into your typical kind of position of some hip flexion, and then you extend the knee like you're doing kind of a popliteal angle. They stretched the hamstring while the children were laying in a CT scanner, and then they drew a line here through the ischial tuberosities. The um, they drew a line through the triradiate cartilage. There it is, and it uses the reference line, and then they looked and measured how far back the posterior of the femoral head or the posterior epiphysis migrated backwards while they performed this stretch while the children were in the CT scanner. So basically, the child went into the CT scanner in this position. They took a scan, and then the therapist extended the knee and stretched the hamstring, and they took another picture. And this is the hip with dysplasia, and when the child was laying there, and this was kind of at the baseline, when this is the baseline position, and then when the hip moved more posterior. So you can kind of see it here if you look at the back of this posterior epiphysis related to this part. This is now dropped below the level of this. So they basically demonstrated that the luxates more or dislocates more when you stretch their hand. And so the study results substantiate the hypothesis that spastic contraction of the hamstrings induced by a stretching exercise would further displace the femoral head when the hip subluxation existed. And they do have some recommendations. So they say that this would also occur if you did it like with a straight leg raising maneuver. And what they're recommending then is if you're going to do any stretching, it's important that the hip is in some type of abduction as they start to extend the hip, extend the knee. All right, so let's talk through what all this means. First, here is the AACPDM hip guidelines, and this is what was referenced in the article here. So when we were talking about this, and we were talking about how children with cerebral palsy have a higher risk for level. Um, this is the AACPTM hip surveillance website. You can just type in AACPDM and surveillance, and it has its own web page. And this is where you can find the decision tree and all the recommendations on how often they should be screened. Now let's talk about something else. Let's talk about standers. So I'm not anti-stander, but I want everybody to recognize that the standing position when you're in a straight plane stander is the same position as what we were seeing with the cradle board swathing diapers. This is forcing the hips into extension and the knees into extension. So anytime we put a child in a straight plane stander who's at risk for hip dysplasia, this is probably not the best position for their hips. A bit of predicament because we know standards are good for other things. But I would like to push back a little bit that a stander is the best positioning device for hips. My recommendation on this is we should never use standers for stretching. And that's what I get a little worried about, especially when you have a stander like this and this lady's got this crank. Basically, it's a hydraulic, jack. It's knees, so the hips are in flexion, the knees are extension, and you're using that device to really pump through and try to stretch those contractures. A standing device is probably not the best device for contracture management. You're probably just going to cause the hips to subluxate and dislocate when you do that. Now, using a device like this and you're just bringing the child up to the point of contracture, I don't see any harm in that. And I think then you can still get the benefits of standing, but without trying to push through the contracture. But I get worried because a lot of times these devices, lots of different people putting the child in the positioning device, could be an aide, could be a teacher. And it's just important that everybody understands that this device is not for stretching. We don't want to use it for stretching. The other advice I would give on standers is if the child can be put in some hip abduction, like this child, right, then that's going to be a safer position for the hip. And if as the hip can be reduced and put into place before you get them into that position, then that's going to be your better use of standing frame. And then let's just talk through recommendation. So number one, hip flexion is healthy. And I think hip flexor stretching is always guarded if you have anyone that's at risk for hip dysplasia. So we tend to want to really go after hip flexors a lot just because they are big muscles. In prone positioning, I get it that it could kind of get in the way of being able to be in that position and fire your glutes. But it's not worth the risk of the hips being subluxated and becoming painful when the child's older. And in most of these children, let's say older children with cerebral palsy, and when I say older, we're saying kind of 4 or 5 year olds who are GMFCS 4 or 5. They are not going to be doing a lot of meaningful walking independently. And so the hip flexor in a sitting position, they are never going to have a contracture that's going to get in the way of sitting 90-90. So what's most important for them is being able to sit and having sitting balance. And then if we can give them hip flexion and then a little abduction that widens their base of support and allows them to be able to sit and have a good base of support and also have healthy hips. Once that hip becomes painful, let's say they start to get in their teenage years, young adult years, and that hip is out and it's causing them a lot of pain, then they're not able to sit and then they're not able to access their environment. And we really have to prioritize the positioning that's going to be best for that child over the long term. So my message is hip flexion is healthy. And sometimes those hip flexors that are tight, that's actually helping the hip. And I'm going to say I'm guarded against trying to stretch those hips. The other teaching point here is knee flexors cross the hip joint. And knee flexors can get in the way of a lot of things. And sometimes I've seen children whose knee flexors are so tight that you can't get their feet positioned in the right place, even if they're GMFCS 4 or 5 and you're trying to get them sitting and they're up back behind the chair. And I can understand how, from a functional standpoint, that can be hard and frustrating. I think what's important on the knee flexors is you probably can still stretch the knee flexors, but the hip's going to have to be able to be flexed and abducted and maintained in that position so that the hip's reduced. while you actually stretch the knee flexor. So that way, as you're stretching the knee flexor, you're putting the hip in a position where it's staying reduced and conjugated with the hip. So I think you can stretch knee flexors, but you just can't do straight plain knee extension. You're going to have to flex them and abduct them. And then finally, hip abduction's good. We should always be working on hip abduction, but it shouldn't be forced because forced hip abduction for long periods of time can cause avascular necrosis of the femoral head. So, some of my messages, especially if we have children that are at a high risk for having some developmental disabilities down the road, from birth, we want to tell the family whenever it's diaper changing time to flex the hips up. We want to hold the hips up, keep them flexed, flex the hips and knees, make sure we can get that position. And then we want to gently let them go into a little hip abduction and stretch their adductors. Because if we can keep that hip abduction and we can keep that hip from getting dysplastic, that's going to give them the best chance of sitting down the road and sitting on a hip that's not painful. All right, well, those are my take home messages from this strategic positioning talk. Um, so, encourage hip flexion with all positioning. Do not force the hip into extension when there's risk for hip dysplasia. Swaddle the hips and free with the hips free or in some type of flexion. And in children with developmental disabilities, do not use standards for stretching and stop before you get to the point of reaching contracture. Keep in mind, knee flexors cross the hip joint. Only stretch the knee flexors when the hip can be reduced and maintain reduction with hip flexion and abduction. Think of the ortolani position where we're trying to get that hip to go in and stabilize in that position, then extend the knee. And then hip abduction is good, but should not be forced. So follow that clock. So hip flexion to 12 o'clock, and then hip abduction towards 2 or 3 o'clock, or 11 or 10 o'clock on the right, and then slowly work your way out and get a good stretch on those adductors. The message we get from Papa Demetrio is correction takes time, and progressing into hip abduction should occur gently as the motion becomes available. And then use props to help prevent hip adduction. So if you're trying to get the child in prone, you can put a towel roll or lay them over a bolster to get a little bit of hip abduction to prevent the hips from going into adduction. And you can also prop them up so they get a little hip flexion in prone, and you can still work on their hip extensors in that position. And then these are my references for the talk, and I appreciate everybody's attention during this presentation.